Nomfundo, thank you so much for spending the time with us today. Your work in value-based healthcare as a bioethicist as well is a very interesting intersection for me that I want to explore today, both for myself and for our viewers. And value-based healthcare is a topic that is very much on the pulse of healthcare news outlets these days. A lot of talk around NHI, a lot of talk about how we better use funding in healthcare to be able to better serve our population. And in order for this to happen, I suppose all the stakeholders have to play a part, and they all have to play together. And healthcare is a region that doesn't like to change. And we don't like to play by the same rules sometimes, but we're going to have to find a way to work together. We're going to have to find a way to collaborate with each other. But value-based healthcare means different things to different people. And in the South African context, I think this is something that we have to get onto clearly defining sooner rather than later. So, with that being said, how do we balance those definitions between providers, patients, and funders? And what would be a quintessential definition for value-based healthcare in the South African context?
Sure, it's a great question. It's a big question. So let me start with just kind of the textbook definition of value-based care. So value-based care is the intersection of patient outcomes as a function of the costs. So how much does it cost to achieve the patient outcomes that we are currently seeing? And with a little bit of history added to that, the reason why we have the value-based care model is off the back of a failed fee-for-service model, which we've had for the past century. So fee-for-service model is that stereotypical model that we all know globally, where I go to Dr. Basil, who's my GP, and I go get a set of services from him, and he charges me a fee for his services and his expertise, right? And then if he feels that I need additional services like pathology tests, he would refer me to a pathologist. I would get the test, and I'd pay the pathologist separately for their services. And then the doctor would call me back with my path results and have a chat with me that could be billed again to the same doctor. And if the doctor feels that I needed referral to a specialist based on those path results, then I would have to pay my specialist for their services and their expertise.
Yes.
And if I'm hospitalized, I would then have to pay the hospital for their services, etc. So very fragmented patient experience, as you can see. And each of the players that I've mentioned here really derive more value or revenue really from the volume of services. So how a doctor would calculate their value would be what is their fee against by the volume of patients that they're seeing. And that's exactly the same for specialists as well as hospitals. But what's interesting to note here is that there is no one within this value chain who's being incentivized for patient outcomes. Wow. Nobody's asking the question, how effective or appropriate was the care given by GP Basil, by the pathology lab, by the specialist, and by the hospital?
Goodness.
Nobody is also being incentivized by keeping my healthcare costs low. So what's happened off the back of that fee-for-service model is that there's been unrestrained spiraling of healthcare costs for patients, particularly in developed countries, because there's no regulation. I mean, it can be whatever it wants to be, right? So value-based care then is kind of the remedy to that idealistically, right? Where doctors will still get paid for their services because they have earned them.
Yes.
And everybody in that value chain, the path labs, the hospitals, the specialists, etc., would still get paid for their services, but there'd be an additional incentive for improving patient outcomes as well as lowering the total cost of care for that patient.
Gotcha.
So it's really value-based care, to go back to what I said earlier, is the change in patient outcomes as a function or related to the change in the total cost of care for the patient in that particular disease area.
So you mentioned outcomes.
Yes.
Outcomes need to be measured.
Yes.
And we need quality measuring tools to make this actually happen. Measuring tools that I know there are a couple of think tanks out there that are trying to formulate them and trying to figure out how we go about having a independent, unbiased sort of measuring a way we could measure the outcomes going forward. With that being said, and with NHI sort of on the horizon coming through, what are some quality measurement tools that we can maybe look to, or models that we can look to, maybe even in developed countries that they have utilized to figure out value-based care and how we best provide the best possible experience for everybody involved in it. And I know this is an evolving thing. It's changing all the time. There's no perfect answer. But maybe just some of your insights into some of the measurement tooling that has already been established and used within figuring out whether we are actually delivering an outcome that is viable and is worth pursuing going forward.
Absolutely. So yeah, that's really what the kind of the rate limiting step of value-based care is. It's around the data, because it is a data-driven system that says these are the metrics that we have set out to achieve per patient within a given population, disease population or medical condition population, as literature calls it within the value-based care environment. And this is how we're tracking against those.
Yes.
So there's a lot of different systems that are being utilized across the world based on the country, based on the type of provider that you're at. But essentially it all comes down to digitization of healthcare. Digital tools. We need to have digitally enabled practices.
Yes.
We can't have those yellow folders. You cannot interpret data that's, reams and reams and reams of data.
Yeah.
I've been with my doctor for 12 years. You
Yes.
can imagine
Yeah.
the accumulation of just reams of paper and information
100%.
over those 12 years. There's no way she can, she can absolutely try to the best of her human abilities, but there's no way she could encapsulate
Yes.
very easily, everything about my healthcare journey and my healthcare status.
From folders that are sitting in a cupboard somewhere that she only looks at when you actually arrive. And not that we expect them to look at it when you're not there, but I mean, the retrieval and the recall of that data needs to be accessible and needs to be put into a framework where it can be measured, not by humans who are prone to error, but by the tools that we have, that technology allows us to now access. I mean, and also with artificial intelligence being able to interpret that data, the margin for error decreases even further. And maybe just even speaking into that, I mean, it's something that we seriously have to look into.
Absolutely. So that's exactly it. So these reams of paper are really difficult to sort out. Now, if that's just me at a single patient level, now imagine this doctor who has a population of, let's say, 1,500 diabetics.
Yes.
Now, how would they be able to track that at an individual level and then be able to consolidate it at a population level and draw insights that are meaningful? How effective is my care plan for these diabetics?
Yes.
What amendments need to be made? How am I tracking to these key patient metrics?
Yes.
How am I tracking to the total cost of care of this care plan?
Yes.
None of that is possible without digitization. And so one of the things that we are doing as Healthbridge, the health tech company that I work for, is that we have created an electronic, a fully cloud-based electronic medical record, which is called Healthbridge Clinical, which completely eliminates the need of a medical of those yellow files.
Wow.
It literally can absorb all of that information and present it in a way that is easy to absorb by the doctor, in a way that is easy to migrate. As a doctor
from one tool to the other.
Absolutely.
Yes.
Even in the consultation where they find everything. And the reason it's so easy is that we have created it with design doctors. It's actual doctors that have sat down and said, this is how we like the flow of our consultations to be. This is how we like information to be presented. And we have over 3,700 doctors that are completely, in our cloud-based environment, particularly on our practice management application. But in our clinical environment, we have about 1,500 that are completely immersed in that world. Wow. And the rate of adoption of digital tools in South Africa is slow, but it's growing. So the impetus for more doctors coming onto those digital tools is really important, particularly those electronic medical records, because that's really where the rubber hits the road in terms of, that data analysis. And, what we're also now building is a value-based platform within that Healthbridge clinical tool that I spoke about, which will be able to consolidate, that information for a doctor at a population level, so he could do population health management more succinctly, leveraging AI, which is something we use a lot of within our clinical space, just to improve, remove biases, improve accuracy and efficiency, etc., and be able to present dashboards to the doctor so he can see how he's doing, and also present those same dashboards to funders, the different funding organizations, administrators, your discoveries, your med schemes,
Yes,
etc.,
yes.
who would be the ones paying the doctors for their services and being, the ones who would also be able to reimburse the doctors once they meet those value-based key metrics that are agreed on within contracts.
So if I'm understanding you correctly, and this is something that I do want to dive a little bit deeper into. The practitioner can enter that information into the database.
Yes.
It's there for their recourse, so their daily functioning and their daily administration of their practice is possible.
Correct.
But then further to that, they can take the insights that they get from the data, and maybe they went into this practice thinking, I'm going to see 50% hypertension, 20% diabetic, and 20% arthritis, for example.
Mm-hmm.
But then the data comes back at them, and they can now say, but hang on, in where my practice is located, maybe I've got multiple locations as well. This practice seems to attract a whole bunch of diabetic patients. For some or other reason.
Yeah.
I don't know, maybe the cultural, the food that the people eat in this particular area lends itself to diabetes.
Or their specific ethnic group.
Ethnic group, correct, yes,
Yeah.
And now they can almost optimize their practices for a specific pathology that they treat quite commonly in that particular area. But then furthermore to that data then allows them to be able to think about solutions that they could possibly provide.
Yeah.
And then work with funders, work with patients, work with fellow providers to be able to come up with value-based systems and value-based solutions that they could then present to people. And again, the funders are key to this discussion. They have to have enough data to be able to aggregate to them to be able to make a case. And then you've got to get actuaries involved to do the funding model and all the rest of that thing. So Healthbridge is now looking at facilitating this data to be able to do this now.
Yes, absolutely.
Okay.
Absolutely. Right. I mean, to a small level, it's already available at a doctor-patient level. What we're now working towards, because we see the proliferation of value-based care, I mean, it's everywhere, across all the different kind of funding groups that we work with. We're looking to do that at a population level now. And then it's going to provide, obviously, better insights from a disease management area that can then obviously benefit the funder as well as the doctor. And obviously the patient is the biggest winner here, because with that data they receive, the doctor is able to refine their care plans, and therefore the outcomes of the patient should theoretically improve, as well as the lowering the cost of care to patients.
So you mentioned that technology adoption is slow in the South African context, but I think it's even slower in the healthcare context within South Africa.
Correct.
Let's speak to some of the ethical considerations that one has to take into consideration. You are a bioethicist yourself, so this is something that you can speak with a lot of authority on. But some of the ethical considerations, because with technology breaches and leaks, and I mean we even have legislation now that's been put in place with Poppy to curb this kind of thing. What are some of the steps that one has to take when considering integrating technology, integrating artificial intelligence, integrating data aggregation, for the purposes of coming up with a value-based solution when you are in healthcare? Like, what are some of the things that the first steps you would take? And I want to ask you to bring this down to a micro level as a practitioner, and then also from a macro level as a company assisting practitioners to leverage data.
Great question, and it's such an important question, because the ethics in healthcare really must always take the fore. We can innovate, but not at the expense of people. These are real people. Yes. So it's a great question. I would start with a data governance framework, and that's even at a practice level. I mean, I think that carries through. But you absolutely have to have one at an institutional level. If you're a large hospital, or you're a funder, or you are a managed care organization, you absolutely have to have a data governance framework that builds on Papaya that we have already, but obviously speaks to the healthcare aspects of it, and that's obviously and that's also at a practice specific level. What are you committing to? What are your parameters in terms of data privacy for your patients within your practice? Another thing that you obviously need to look at is consent. How do you obtain patient consent at different stages, like when you have to share a patient's data with a specialist, which is going to be important or become more important within value-based healthcare, because value-based healthcare it emphasizes care coordination across different specialities. So doctors aren't working in silos anymore. A GP would work in a team with a specialist. And if we're looking at a diabetic, it could be a podiatrist, it could be a dietitian, a social worker could be involved. If there's some sort of a social dynamic that needs to be addressed. There could be a physiotherapist if there's an amputation that's required.
Yeah.
All of those people now have to form one team, and it is this, what we call an independent practice unit within the value-based environment, that would then receive the benefit of the value-based care incentives based on how well they're able to treat this patient or this group of
So I'm getting a bit scared now, because now I'm thinking to myself, okay, how are all these people going to work together when they are so used to, and they're brought up in a system that purposely silos them?
Yes.
I mean, where do we even begin to think about? So I think the managed care companies have their work cut out for them. They really have to get the buy-in of the practitioner to even begin to bring a solution like this. And I mean, I don't know if you obviously have worked with some managed care companies. Maybe just if you glean some learnings that they've had on how to get them to collaborate.
Yes. So it's really about them buying into the fact that they're not going to lose revenue. It's all going to come down to that, because the fear is really based on, am I going to lose money by partnering with a dietitian in this instance? And
is it going to be infringement on scope? Is it going to be, because we're all like very protective about
Absolutely. And the reality is no. I mean, if you are an endocrinologist, you're an endocrinologist, and the work that you will do for the patient in this example will be specific to you.
Yes.
What's going to become very important, though, with value-based care is that every speciality is going to have to start working at the top of their license. Because value-based care emphasizes the need for a strengthening of primary healthcare services and using the lowest viable option of care. So if a nurse can do something, the scope that nurses can do is going to start pushing up on GPs.
Yes.
GPs need to level up.
Yeah.
And a lot of what specialists are doing now is actually GP work. I mean, I was born in the 80s, and I remember a time where GPs used to even do little surgeries in their rooms.
Yes. Well, they're called surgeries.
Exactly. Absolutely.
They're not good. It doesn't say GP on that. It says doctor's surgery.
It's a surgery. So that I come from that time. And essentially, value-based care is bringing us back to that.
So ego is going to be a big problem now.
Ego is going to be a big problem, but I think there's going to be, over time, an understanding that this is all for the best for patients. At the end of the day, we all serve patients.
Yes.
But it's also going to force the doctor to just level up and work at the top of their own of their own license.
So, I mean, I've just a short story I can share with you is I worked with a company that does point of care ultrasound devices.
Awesome.
And in Central Africa, nurses are now doing point of care ultrasound to date pregnancies.
Lowest viable, treatment option, right? Like.
So because
why not?
They just don't have the staff, the doctor staff required to actually get it out to all these moms.
Yes.
And the World Health Organization has mandated that every mom should have at least a scan in the first trimester.
Absolutely.
The way to sort of decentralize that, let's upskill nurses.
Absolutely.
And get them to do it.
Absolutely.
And so that's a way that burden gets shared. But now, as a primary health care practitioner, as a doctor, I look at that and I go, is my scope being infringed upon? Am I losing my value? But like you say, they need to upskill.
Absolutely. And that's what
and
it's going to come to.
Of their profession.
Absolutely.
Yes. Yeah.
And if everybody pushes up, it means that we're always using the lowest viable option of care.
Yes.
And keeping that total cost of healthcare down, because that's what we're really trying to drive. If you look at a diabetic patient who's diagnosed in their 40s, and we know the average lifespan in South Africa is like 60-something.
Yes.
They have 20-odd years of life ahead of them with the condition, right?
Yes.
We need to look at the cost of that entire 20 years and bring that down.
Yeah, yeah.
And it's not going to work if we are still working this very fragmented, I'm protecting my space and my revenues model and not seeing the wood for the trees.
Yeah.
And the reality is that you could actually make better money in the value-based care system.
I've seen it myself when I bought into certain value-based care programs. I mean, just the security of funds, because now I've been given a certain amount of sessions, I've given a certain amount of leeway with my episode of care, and I know that it's going to be funded.
Absolutely.
So,
Absolutely. I'm glad you have that positive experience and that you can share that.
Yes.
Because I think doctors who've never ventured out into these kind of alternative reambusment model contracts just haven't a clue of what the potential upsides could be. Yeah.
Something I think I don't want to expand too much on this conversation about, but maybe just render my opinion on is that as a clinician, you have the patient has come directly to you. In the managed care space, they've interacted first with the managed care organization, and then they get decanted to you.
Yes.
And then I think instills a lot of fear into practitioners because they're losing that sense of autonomy. And that sense of predictability.
Yes.
And so I think there's a need for legislation between the managed care company and the practitioner that they are not going to essentially lose their lunch with regards to this relationship. Because now there is kind of like a patriarchal relationship with the managed care company and the clinicians sitting over here, almost beholden to them to see their value. And if they don't see their value, essentially cutting them at the knees.
Sure.
I don't want to dive into that conversation right now, but it's a conversation I think we should have.
I agree.
I want to segue a little bit into some of the models that you've seen work really well in the first world nations. What adaptations do we have to do in South Africa to make them work here?
Sure. One of the kind of most prominent example of value-based care globally is Santion. It's in the Nordic countries. I think it's in the Netherlands, if memory serves me well. And it's a group of 7 hospitals, private hospitals, that have come together to offer a value-based care offering to a population of patients. So, and it's worked really well. They've seen amazing reductions in surgeries. They've seen amazing reduction in hospital days, etc. Wow. Massive savings. And so for us in South Africa to achieve those sort of results, it's going to come down to defragmenting the healthcare sector, understanding that all of us, or all of the different providers, are part of a healthcare value chain.
Yes.
And you address every patient issue, and all of you are required for the patient journey. Let's work together. There is value in working together, and I mean that in a philosophical way, but also in a commercial way.
Yes,
exactly. Yeah. There's absolute value in working together.
And I don't want to negate that, because I think oftentimes, the conversation around healthcare is quite virtuous in that, we're all here to help patients and assist patients. But the conversation becomes very commercial eventually when you say to yourself, well, I had to take money out of my pocket to build this practice. I had to pay for that couch, I had to pay for that TV, I had to buy all the equipment out of my own pocket to serve my patients. And so there has to be a commercial conversation. We have to always destigmatize this conversation, because that's the only way I think you're going to get buy-in from the clinicians, is to say to them, listen, we see you, we hear you, we know that you require this reimbursement to be able to provide for your family and pay back your costs as well, But I think there's a good place where those two can intersect with each other.
Absolutely.
And we don't have to have the stigma around it. We have to lift the lid on this thing, because I think unless we do that, we're never going to get the buy-in that we need to really drive this home. But further to your point, I mean, you mentioned that there were some adaptations that perhaps we need to look at. Are there any other beside, looking at, you mentioned the hospital setting. Yeah. Are there any others that you'd like to unpack further to that?
I mean, in my research, so I did my my master's research on value-based care, looking at kind of the global situation. There is no one country that has fully implemented value-based care in its fullest. There's pockets of pieces of value-based healthcare, and people are already, even in that kind of spotty, for lack of a better word, implementation of value-based care, they're seeing the benefits of that. We are also seeing the benefits of that, because we already have value-based care type models that are already in existence today. Yes. So, I mean, there isn't one holistic model, unfortunately, that I can speak to right now. And the data obviously varies by country, also by the different contract or the different provider that's providing it. But I think fundamentally it comes down to, in South Africa, defragmenting the healthcare system and adopting digitization of healthcare. That's really, for me, if there was nothing else, it would be those two things that we would have to move forward with.
Well, on that point, I do want to give you an opportunity to speak about the work that you do with Healthbridge, and the work that Healthbridge does as well to help clinicians better run their practices. And also, I mean, you've mentioned just the other elements that Healthbridge is bringing, the value they bring into the healthcare fraternity and community. So please do tell us a little bit more about what you do at Healthbridge and how Healthbridge can help our audience to better run their practices.
Fantastic. Thank you for that. So Healthbridge is a health tech company, and we started our business 25 years ago. In fact, yesterday we were off-site for the full day celebrating our 25 years, or our quarter centenary.
Congratulations.
Thank you. And the business started as what we call a switch. A switch is literally the infrastructure that allows a practice or a hospital to submit or to send their claims directly to a funder and then for the response to come back. Okay. And so we were the first to provide real-time claim submission, which obviously revolutionized the industry.
For sure.
I'm sure you've benefited from that.
Definitely.
And then over time, we evolved into cloud-based practice management applications, kind of what the front of the doctor's practice system that they would be using to capture your details, to process claims, et cetera. And subsequent to that, we've created our electronic medical record, which I spoke to earlier, which is Healthbridge Clinical. And within Healthbridge Clinical, we have SmartMeds, which is, again, a cloud-based, AI-driven prescription e-script prescription model that sits within there that leverages the data, uses AI essentially to kind of leverage the data that what the doctor has usually prescribes for a particular condition, as well as the cohort, similar to the doctor in terms of geography, mix of patients, et cetera, what they would also prescribe in that environment for that same condition, as well as 30 million scripts that have been uploaded into the system. So really, really amazing in terms of helping doctors just reduce the burden, reduce just the cognitive burden essentially of having to memorize all of these medicines and how to prescribe them for adults, for in pediatrics, etc. So we're really looking to grow that, our clinical base, because again, everything into the future speaks about the digitization of at least the medical aspects of healthcare, the clinical consultations, etc. So we have about 6,000 patients on a mix of our practice management application.
Patients or clinicians, sorry?
Clinicians. I beg your pardon. I stand corrected.
Yes.
We have 6,000 practices.
Yes.
That's what I meant to say. We have 6,000 practices that are within our environment, which we've built up over the past 25 years. And again, we service them with our PMA as well as with our EMR. And we are now looking at building a value-based platform which will assist with contracting between the funder and the doctor, as well as helping doctors to build these multidisciplinary teams and obviously care coordination within that space as well. Again, everything in that digital environment, allowing for that data analysis, allowing for just the seamless exchange of information and creating a single patient view, because I think that's the most important. That, again, speaks to the defragmenting of healthcare. Because if I go to Dr. Basil and I go to my endo and I go to my dietitian, there are different files and different versions of my healthcare status. So what we're really looking forward to, and especially with the advent of NHI, is that single patient view. So that's essentially what we do.
Well, I'm happy to hear that. I mean, there are technology partners that are partnering with clinicians to, again, better assist them to be able to adopt what the future of healthcare is probably going to look like. And to know that we're going to have that support going forward is a really comforting thought. And thank you to the work that Healthbridge is doing. Thank you for coming onto our podcast and talking about this. I really appreciate your insights are so valuable. And good luck with the work that you are continuing to do to drive this home and bring adoption, particularly with value-based care, technology and artificial intelligence. So thank you again, Nomfundo, for the time. I appreciate it.
Thank you so much for the invite.
And thank you to you, our viewers, for spending the time with us. This has been Vital Insights. My name is Basil. Please do leave us a comment or a like or a share and give us feedback on whether this has been valuable for you. And we appreciate always hearing from our listeners and our viewers. So thank you so much for your time. And until next time, see you.